everybody. My name is Jigna. I'm one of the PEM Fellows, and today we're going to talk about neonatal resuscitation. I think this is a really important topic to talk about because, one, we're early in the year, we have a lot of new interns. It's something that we don't see like often in the emergency room, but it's definitely something that you will come across throughout your training. All right, so our outline for today, we're just going to talk a little bit about fetal and newborn like physiology. Then we'll talk about some of the risk factors, some of the signs and symptoms you should recognize of distress in a newborn. We'll talk about we'll go through the algorithm for NRP, and then we'll talk about equipment and meds and some ethical principles. All right, so which babies require resuscitation? Most newborn babies are generally born pretty vigorous. Only about 10% of them require some sort of assistance to begin breathing at birth, and only 1% of them really need extensive resuscitative measures such as like intubation, compressions, medications. So in order to understand the causes of distress in a newborn, it's first important to understand some of the newborn pathophysiology. So the alveoli, which is the air sacs, we all know that, and the fetus is filled with fluid. And once they're born, the fluid begins to be absorbed and it gets replaced with air. So in the fetal period, usually the way a fetus gets oxygenated is through the placenta. So blood flows through the fetal lung. It's usually markedly diminished in the fetal period, but immediately after birth, like I said, the fluid gets replaced with air. So as the newborn takes the first breaths, a lot of changes occur. It occurs simultaneously and very, very fast. The lungs expand, they fill with air. And all the lung fluid gets absorbed by the alveoli. And as this happens, the lungs are expanding and the fluid gets cleared, the alveoli and the lung begin to open up more, and blood flow throughout the pulmonary vessels begins to happen. So as the pulmonary blood flow increases, the blood levels of oxygen rises in the newborn period. The ductus arteriosus begins to constrict. Previously, blood that was diverted through the ductus arteriosus now is flowing through the lungs, where it continues to pick up oxygen, which is then transported throughout the body and gets delivered to the organs. The ductus usually remains constricted, and in the normal extrauterine period, the circulatory pattern is now established. So normally there's three major changes, like I said, that all happens within seconds. Like I said, the fluid gets replaced with air, the umbilical arteries and the veins, they get clamped. And what this does is this removes the low resistance, like placental circuit, and increases the systemic blood pressure. And then the blood vessels in the lung tissue begins to relax, and this is what allows pulmonary blood flow to occur. So a baby can encounter a lot of difficulties before birth, during labor, and after birth. Some of the problems that can help disrupt this transition to the newborn period are as follows. So the baby may not be able to breathe sufficiently to force the fluid out of the alveoli. There could be foreign materials such as meconium that may prevent like air to sufficiently enter the alveoli and the fluid to be absorbed. There could be excessive blood loss during delivery, which can affect the cardiac contractility, leading to bradycardia, hypoxia, and even ischemia. And then lack of oxygenation and ventilation in newborns' lungs can result in sustained constriction of the pulmonary arterioles, which can prevent further arterial blood from becoming oxygenated. And then lastly, prolonged lack of adequate perfusion and oxygenation to the baby's organs can lead to brain damage to the other organs, and also even result in death. All right. Wait, what? So there are some risk factors that you should kind of be aware of. And a lot of times in the ER, like they're calling a code, they're saying there's a code 54, baby's being born. So it's hard to gather this history. But if you have extra people on hand, it's try to get some history, maybe do some chart review or get as much history as you can if there's like a father or a partner there with the mother. So some of the risk factors just to think about and ask about is so maternal conditions such as advanced maternal age and diabetes or hypertension. Ask for any sort of substance use if there's a history of stillbirth, fetal loss, or early neonatal death. Some of the fetal conditions to think about is prematurity. So is this baby being born at the appropriate time, or is this baby premature or postmature, which is usually like after 41 weeks. Is there any history of intrauterine growth restriction? Is there multiple gestation? Is it one baby or multiple babies? Some of the antepartum complications can be any sort of placental anomaly, such as placental previa or abruption, also oligohydramnios and polyhydramnios. And some of the delivery complications can be a transverse or breech lie, chorioamnitis, so if the mom had a fever somewhere around close to delivery. Also, if you notice meconium stained fluid right prior to delivery or even after delivery, and any sort of antenatal asphyxia. So prematurity can make preterm infants more likely to require resuscitation, and they more at risk of developing complications. The majority of these cases, like they will need some sort of resuscitation. Some of the factors that you want to kind of think about is hypothermia, because they have such a large body surface area to mass, and their skin is also very thin with decreased subcutaneous fat. So that increases their risk of becoming very cold. So if you have a premature infant being born, you want to make sure you bring them to the warmer right away. In the NICU, we have like this foil that you put on the baby to help like warm them immediately. We don't generally have that in the ER, but just put them in the warmer, try to put blankets around them as soon as possible. The smaller the infant, generally, the more difficult it is to bring them up to like a normal temperature. Other things that you want to think about because of prematurity is inadequate ventilation. And this is basically because they're deficient in surfactant. So you may need to give surfactant to help them out a little bit. And then their immature respiratory drive and their weak respiratory muscles increase their risk of apnea as well too, and which also leads in decreased respiratory effort. They are also at risk of infection because their immune system is not mature yet. And then organ damage as well too, again, because of immature organ tissue and capillaries, which make them at increased risk of bleeding as well too. So what should you do in preparation prior to birth? A lot of times we don't have time to do this, but as much as you can, try to like, use all the resources and the people you have to divvy up the task. So the first thing you need to do is call a code, know the code that's specific to the hospital that you're at. At Kings County, it's code 54. Not quite sure what, yeah.
There's a new app for in, I believe, it's probably if you
Mhm.
have it listed right by the attending desk,
Mhm.
and there should look and familiarize himself with the protocol.
Oh, I didn't know that.
And
What is the no?
plain language code. I think.
Plain language codes?
Yeah.
Oh, okay.
But to be aware, thank you is not common unless in.
Yes, exactly. So if you know a baby, that's where I was gonna say. So when you call a code, OB will come. NICU will not come. If you know a baby's being born, have a student, a resident, somebody call the NICU and let them know that there is being a baby being born, and they will come down right away. And it's good to have them there just in case you need to put in a line, because obviously, like, they're the experts at doing this, and they could put it in much quicker than we can. Yes. Yeah. So if you tell our charge nurse, they're gonna, and we know the baby's being born, they will roll over the baby warmer as fast as possible. Usually is in 3R is where we do like the resuscitation. So they'll bring over the radiant warmer. You want to make sure you plug it in, you turn on the temperature to get it like to adequate temperature right before the baby is born. You want to make sure you have blankets there. You want to make sure you have all the suctioning apparatus, bulb syringes, almost everything that you need is right in like the little drawers in and under the warmer. So you should have cord clamps there. You should have blankets there. You should have hats there. Everything that you need. You also want to make sure that you have an oxygen source plugged into the wall. You can literally just plug in a nasal cannula to the wall, put it on like 10 or 15 liters, because in case you need to give just free flow oxygen, which we'll talk about in a second, it's readily available to you. And then obviously think about all the intubation materials that you may need, the laryngoscope, the ET tube, the stylets, which we do have a neonatal cart in 3R, which has all of the appropriate equipment that you will need.
And it's-
Yeah.
Right, where we get your uncuff and your cuff.
Mhm. All right, so the baby's born. Immediately after the baby's born, there's a few questions that you want to have answered if you have the time, because these will help guide your treatment as well too, and give you an idea of what type of resuscitation may be required for the baby. So you want to know the gestation of the baby. You want to know if the amniotic fluid is clear or meconium stained. If it's meconium stained, they might need a little bit more help breathing, and this is something that you'll probably see when the baby's being delivered. And then you want to note if the baby's breathing or crying, and you want to note the muscle tone. All right, so there's a few signs that you can look out for that can tell you if the newborn is compromised or not. Look for muscle tone to see if they're limp or floppy, which are not good signs. Look for any depression of the respiratory drive that, again, can be due to like insufficient oxygen. They may be gasping, they may be taking shallow breaths. Have them plugged into, like if you put on a pulse ox, you can check their heart rate to see if they're bradycardic or not. You want to check their blood pressure, look for their respirations, see if they're tachypnic or bradypnic as well too, and then look for their color. Most babies will have some blue hue and cyanosis to them, but what is normal and what is not normal? So having central cyanosis is never a good sign versus having acrocyanosis, which is just cyanosis in the distal extremities, is normal in almost any newborn. All right, so this is the NRP chart. You can easily pull it up. You don't need to memorize it. You have multiple things to memorize already. Have somebody pull this up and you can literally go through the algorithm for newborn resuscitation. So we're gonna go through all the ABCs of NRP now. And we're gonna go through the algorithm as well too. So what are the initial steps? We talked about it a little bit already to establish an airway and resuscitate a newborn. So you wanna provide warmth to the newborn. As soon as the baby's born, you wanna bring them to the infant warmer. You wanna dry and stimulate them, and you can literally do this just by taking like the baby blanket, dry them as much as you can, then you can pat them on their back. You can flick them on their toes, and usually they cry, and we'll give you a nice vigorous cry this time. If you feel like they're having some trouble breathing, put them in like a good position called the sniffing position, which I will show you pictures of in a minute. And then suction them as deemed necessary. You usually want to use a bulb suction, but if that's not available, you can also use a suction catheter. You always want to suction the mouth first and then the nose. So what if meconium's present? So if the newborn is born vigorous, you can just do suctioning of the mouth and then the nose, and then provide any sort of other resuscitative measures that are required. If the newborn's not vigorous, then again, you want to suction them as well too, but you want to try to stimulate the baby to get the baby to cry. And if the baby's not responding, the baby might need some positive pressure ventilation. This is the sniffing position that I was talking about. So you want to put the baby on the back or the side, and you want to just slightly extend the neck to straighten out the airway, as is, I don't know where my markers, as is seen in this picture. You don't want to hyperextend them or flex them because then you'll have difficulty providing proper oxygen. So after the initial steps of warming, drying, suctioning, and stimulating the baby, which usually takes about 30 seconds to do, you want to evaluate the baby every 30 seconds. So always reassess, reassess, reassess. You're evaluating them for their respirations, their heart rate, their color. If the newborn is not breathing or has apnea or has a heart rate less than 100 beats per minute, then you continue to move down the algorithm. This is a cyanosis that I was talking about. So Again, you can see in one picture, the baby has acrocyanosis. It's more cyanosis on the central trunk and the face versus in the second picture, you see just like the hands are blue. Central cyanosis is generally caused by too little oxygen and blood in the blood and can cause like this blue hue to the lips, the tongue, and the central trunk. Only central cyanosis is the one that really requires true intervention. You want to assign APGAR scores. This is usually done at 1 minute and 5 minutes. Again, you don't need to memorize this. Somebody can pull up the APGAR chart and you can kind of go through it. So A stands for appearance. You give 0 points if they're blue and pale. You give 2 points if they're pink. If it's somewhere in the middle, you get 1. P is for pulse, absent pulse, 0, pulse greater than 100, 2, anywhere in the middle, 1. Grimace, so their reflexes, if they're floppy, they get 0. If they respond promptly to your stimulation, they get 2. Minimal response, 1. Activity, so the A is for activity, which is muscle tone. Absent muscle tone, 0. If they're active, 1. If they have flexed arms and legs, if they're active, 2. Flexed arms and legs, 1. And then respiration, absent respiration, 0. Vigorous cry, 2. Slow, irregular cry, weak cry, 1. Again, you don't need to memorize it, just pull it up. Yeah, that's why when you guys do NICU, you'll notice that APGARs are almost always like 9-9, and it's because of the color, because they're always going to have that cyanosis in their hands and their feet. So they usually lose that 1 point for color. Yes. Yeah. Mm-hmm.
But really important is that the mucus membrane should not be blue.
Yeah.
So, like you can get it or like around the mouth, but if your mucus membranes are moist or mucus membranes are blue, that's people. Very well. If you're looking like within the mouth, anything like that, sometimes the lips themselves, and then you can still see a little bit of blue, but anything you get like inside. Yeah.
Yeah, you can commonly see like mustache, chin, still a little blue, but.
For a few minutes, yeah, and it should go away. Okay, so moving on down our NRP algorithm. So, all right, so we've tried stimulated suction the baby, and now we want to assess for any sort of apnea, gasping, and we want to assess their heart rate. So if they are apneic or have a heart rate less than 100, then you move on down the algorithm. You want to consider giving them PPE. You want to put them on a pulse ox and put them on a cardiac monitor. At this time, you should also have somebody kind of setting up for intubation, getting all of your supplies ready just in case. If they just have a little bit of labored breathing, their heart rate is more than 100, you can just provide a little bit of suction. You can do some blow by oxygen as needed, or give them just a little bit of CPAP, which we'll talk about in a second. So these are the ideal saturations after birth. So don't be surprised if at 3 minutes the baby sat is 73%. Don't freak out. That is normal for their age. So always, this chart is also on the NRP like chart as well too. So you can look at this and see what the normal saturation should be in the minutes post birth. Yeah.
Reassure them.
Yeah.
Just look how long it takes.
Yeah. 10, 12 minutes. It takes a while. You don't need to give them any extra supplemental oxygen or anything. It just takes a while for them to reach normal saturations. All right, this is how you can give them free flow oxygen. Like I said, just connect the nasal cannula to the wall, and you can just put the nasal cannula right by their nose and kind of create like a small little cover with your hands, just to allow as much oxygen for them to take in as much oxygen as possible. If you have a face mask and you want to plug in the face mask to the nasal cannula, you can do that as well too. PPV, there's two ways you can give it. You can use a BVM to give it. Usually you want to use a self-inflating BVM that has like a pop-off valve, and this makes overinflation like less likely. You can also use a T-piece connector, which is in that second picture, which we commonly use at Kings County Hospital and here at Downstate. And this is a good way to consistently deliver a good pressure. So if you put just the T-piece connector on the patient, they're getting just CPAP. But if you occlude the opening at the top where his finger is at, I can't see from this picture, you're giving them PPV. So every time you occlude it, you're giving them PPV. But if you're just putting it on, you're getting just CPAP. All right. Very important, you want to make sure that you have the appropriate size mask. Although you may think one mask will fit all, it will not. Especially if you have a premature infant, you may need a much smaller size mask. You want to make sure the mask covers their chin, their nose, and their mouth. If it's barely hanging off of the nose or not covering their chin appropriately, they might not be getting like a good adequate seal to get good oxygen delivery. So the frequency of ventilation. So if you want to give just oxygen so this is for a baby that has a little bit of labored breathing, their heart rate is still greater than 100. You want to give at least 40 to 60 breaths per minute. 40 to 60 breaths per minute. So some signs of effective ventilation. So you will see an improvement in their heart rate, in their color, and their muscle tone. And then you'll also see like their saturations going up, and you'll see them starting to take breaths on their own as well too. All right, so this is everything this is the part of the algorithm that we've been through thus far, and this should all take about 1 minute to do. It sounds like a lot to do, but in reality, it goes by really quickly. So yeah. Okay, so moving on down the algorithm. So we've done all of everything up until a minute now. We want to reassess the baby after 30 seconds. And you want to ensure that the baby's receiving adequate ventilation. So the baby had less than 100 at a heart rate of less than 100. And then we reassess the baby. So what if the baby has a heart rate more than 100 now? So if the heart rate improves more than 100, then you move on, give them post-resuscitation care, wrap them up in a blanket. They can hang out with mommy. But if they're not improving and the heart rate still stays less than 100, then this is when you want to start thinking about intubation. So you're giving them PPV. You want to make sure that the PPV you're giving is adequate, which we'll go through in a second. Once you've decided that it's adequate and it's still not improving, then you want to think about continuing and gathering all your equipment for intubation. So how do you assess for adequate ventilation? Mr. SOPA is the mnemonic that we generally use in neonatal medicine. And again, this chart is also on the NRP card as well too. So you can, again, just go through it. You don't have to memorize it. So M stands for mask. You want to make sure that you have the appropriate size mask and it's covering the nose, mouth, and the chin. And R stands for repositioning the head. So you want to make sure the baby's in the sniffing position. Once you've done these two, you want to give PPV for 30 seconds, reassess the baby. If you see chest movement and the baby's doing well, that's it. If you feel like there's no chest movement, the baby's not improving, then you move on to the next steps. S stands for suction. So you want to suction the nose and the mouth again. And then O means opening the mouth. A lot of times the babies, they'll be trying to breathe through their nose and their mouth will just be closed. So you want to try to open the mouth as much as possible. So once you do those two steps, again, you give PPV for 30 seconds. Look for chest movement, chest rise. If there's appropriate chest movement, chest rise, you can stop here and continue just giving PPV. If you don't see appropriate chest rise, then you move on to the next, which is P is pressure. So you can increase the pressure on your PPV. And then again, give 5 breaths, look for chest rise. If the baby's still not improving, then you have to think about the alternate airway and intubation. All right, so we've confirmed adequate ventilation with appropriate chest rise. We've given PPV for 30 seconds. So if after 30 seconds of adequate PPV, the heart rate it becomes less than 60, then you have to start doing chest compressions on the baby, just so you can ensure that the baby gets appropriate and sufficient cardiac output. You want to support their circulations with chest compressions while simultaneously continuing ventilation on the baby. Okay, and then at this point, the newborn should also be connected to the monitor. And then if you don't have all your ET tube materials ready at bedside, you can just give the baby oxygen use the BVM while everything gets set up. So how do you do appropriate chest compressions in a newborn? So you always want to make sure you're compressing 1/3 of the AP diameter. And at this end, the baby should also be connected to cardiac monitor. And then, like I said, it should be accompanied with ventilation. And you will need 2 people at this time, 1 person doing compressions, 1 person doing the ventilation. And you should be at 100% oxygen when you're ventilating the baby at this point. There's 2 ways to do compressions in a newborn. You can use the 2-thumb technique, or the 2-finger technique or the thumb technique. The thumb technique is usually you're using both your thumbs and putting them on the baby's sternum while you're using the other 4 fingers to encircle the baby's trunk, and then you're just compressing 1/3 the diameter like that. Or you can use the 2-finger technique where you're using your index and your middle finger to just press on the sternum, with the other hand supporting the back. So 1 compression and ventilation cycle should take about 2 seconds. And in those 2 seconds, you're providing 3 compressions in 1 breath. And the way that we generally do it is we say breathe 2, 3, breathe 2, 3, breathe 2, 3. So when you say breathe, they get a breath through PPV and they're getting compressions continuously throughout. So in 1 minute, there should be about 120 events that happens with 30 breaths and 30 breaths and 30 breaths and 90 compressions. So the NRP chart is great again because they provide you with all the ET tube sizes that you will need and the depth depending on the gestational age and weight. Again, you don't need to memorize it. You can just look it up depending on what the gestational age is. The laryngoscope size. So if it's a preterm infant, you want to use a double 0 or a 0, and they're all Miller blades. Or if it's a term infant, you can use a 0 or a 1. You want to make sure you're checking the light on the laryngoscope and to ensure that it's working, because you don't want to be intubating a patient and then realize that the light is not working. Have the suction readily available and plugged into the wall, and it should be set between somewhere around 80 and 100 millimeters of and then you want to make sure that you use a large suction catheter. We usually use a 10 French for any sort of oral secretions. If you have a preemie, you might want to use yes. Yeah. 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 Has it happened to you before? Yeah. Yeah. So use a 10 French for suction. If it's a smaller baby, you might need a smaller French catheter. All right, so once you intubate the baby, you always want to confirm with a radiograph. They might not be there readily available, so always have it entitled to there, and then listen for breath sounds bilaterally. You can see in one image, there's a right main stem intubation versus the other one where it's in the appropriate location right above the carina. So special indications for intubation in a newborn. So if they're extremely premature, then they're gonna almost automatically get intubated and they're gonna get surfactant right then and there. And then if you suspect a diaphragmatic hernia as well, these patients need to be intubated. So when do you want to consider a laryngeal mask? So any patient that may have any sort of cranial facial abnormalities, small mandible, or large tongue. There are limitations, however, to using a laryngeal mask, and that's basically the fact that you can't really suction if you really need to. And then it's really unknown if it's as effective, like an effective way of oxygenating the baby while you're doing compressions at the same time. And you may not be able to use like high pressures as well too, with the laryngeal mask. And then if you have like the very low birth weight babies, you might not have like appropriate size for them. All right, so after 60 seconds of chest compressions and PPV, we've intubated the baby. We want to evaluate the newborn again. If the heart rate is still less than 60 at this point, then you want to start thinking about medications to give the baby, specifically epinephrine. And then you want to also consider like what are the other alternate etiologies of why is this baby not improving despite getting adequate ventilation. Epi can be given like every 3 to 5 minutes as deemed necessary. And then again, you don't need to memorize the doses. It's all available to you on the chart. It tells all the doses are outlined very nicely depending on the route that you're going to give it. You can give it IV or IO if you have those accesses established. If not, you can always give medications through the ET tube as well. And the doses for ET tube is written here as well. So in the ER, it might be difficult for us to obviously get a line on this newborn or establish like an umbilical venous access. So ET tube and IO are really good options for us. If you do want to put in an umbilical line, I'm not going to go through all these steps. You guys are going to have plenty of time to practice this on one of your procedure days. And hopefully the NICU's there to put in the line at that time. So some indications for volume expansion in a baby. So if the baby's not responding to your resuscitative measures, if the baby appears to be in any sort of shock, so pale color, weak pulses, persistently low heart rate, not really improving despite everything that you're doing. And if they also have like a history of fetal blood loss, so if mom had a lot of vaginal bleeding during delivery, if there's placental abruption, or placental previa, or if this is like a twin delivery and there's a history of twin to twin transfusion, the baby might need additional fluids. The recommended fluid that we generally like to use is normal saline. If you don't have normal saline, you could use lactated ringers or ORH negative blood, but we almost always have normal saline. The dose that you want to give is 10 ml per kg. Don't be surprised if it's a really small amount that you're giving them and it's basically through a syringe because these are small babies. So if it's a 5 kg baby, you're only giving like 50 mLs to the baby. The preferred route is umbilical vein. You want to make sure that you drop the correct volume and you want to give it like a little slow over 5 to 10 minutes. Yeah, literally. And that should be enough. Yeah. And then some signs of improvement that you should notice at this point is the improvement in their heart rate, in their pulse, in their color, and also in their blood pressure. If they continue to be hypovolemic, you can give additional boluses as deemed necessary. Okay, so we've gone through the whole chart. Everything that you need is here, including the algorithm, Mr. SOPA, the mnemonic, to ensure that you're giving the baby adequate ventilation, the saturations that are normal for the age of the baby, all the medication doses, and the sizes of the ET tube, and the depth of the insertion that you need. So you can just have one person pull this chart up and everything that you need will be available to you right then and there. You don't really have to think about it too much. So some ethical principles of neonatal resuscitation that I just wanted to talk about. It's the same that we think about when we treat our adult patients and other children. So always think about autonomy, beneficence, non-maleficence, and justice. And then the laws really do vary depending on where you're practicing, which state and which hospital you're specifically practicing in. But based on most of the available data, preterm infants born usually below 22 weeks of gestation are generally not considered viable at most centers. I know here at Kings County, we do resuscitate sometimes the 21 weekers, and they generally do well. So wherever you're practicing, just kind of know what they follow and in the NICU. And then there's no federal laws that mandate resuscitation in all circumstances. And then withdrawal of support is appropriate if you feel like all the measures and everything you're doing is futile. In the case of a death, you really, I mean, this is a very sensitive situation, right? These parents have probably been waiting for this child for 9 months. You really want to involve the parents at this time. You want them to be there. You want to encourage them to hold the child. You want to try to reduce any sort of pain or stressors that the parents or partners may be going through, and just be culturally sensitive, because especially in the community that we practice, we come across people from various different backgrounds. So just be sensitive to people's cultural practices and whatever spiritual needs that they use. Yeah. So these are just some of the pearls from NRP. So one of the most important and effective action in neonatal resuscitation is to ventilate the baby's lungs. Effective positive pressure ventilation is this to secondary apnea usually results in rapid improvement. So you should see the baby improve almost within a few minutes. If the heart rate does not increase despite adequate ventilation, then you want to move on to chest compressions and think about other medications that you want to give. Question.